Okay, so welcome to the first Women in GI meeting. This organization was created to help increase networking among women practitioners, both physicians and advanced practitioners. Being a virtual visit again, I'm glad our Southern Cal colleagues were also able to join. This committee is currently headed by me and also Dr. Mariana Reutman, who works as the associate professor at UC Fresno, and she is in the meeting. I'm glad she was able to join today in the meeting after she had a dental visit yesterday, an emergency one. And I'm happy today that we have two speakers in different aspects of GI with great achievements. And again, thanks to sponsors and also to the speakers today. So I want to first introduce our first speaker for today. Again, thanks to Dr. Uma Mahadevan for again joining us to give another great talk today. She doesn't need any introduction. We heard her give her a great talk today. We couldn't think of anyone else besides Dr. Uma Mahadevan today who has great achievements under her belt. She's currently professor at UCSF. She's director for IBD at UCSF. She completed her education training with medical school in State University of New York, residency at Mount Sinai, and fellowship in GI at UCSF. She completed IBD fellowship at Mayo Clinic. She is a committee member, chair to multiple national, international committee members. She has multiple publications in regards to IBD in pregnancy. There is another reason I invited Uma to give the talk today. She was the ex-president for NCSCG in the past. So today Uma is going to give us a talk about disparities in medicine, and I'm honored for her to be with us today. Thanks, Uma.
Thank you, Radhika. Thank you for the invitation. I'm just going to share my slides. So today's talk is really very brief. I just want to give a framework to talk about where we are as women in medicine and where we can expect to be. I think I am probably much older than many of you on this, which is why I was a longtime ex-president of the NCSCG for many years ago. But when I first went to DDW as a trainee, there was never a line for the bathroom. And that has changed dramatically now, where when we get back to DDW in person, not this year, but hopefully next year, you'll see that that has changed. And that's our surrogate marker for how we're doing. But these are some slides from the AGA about how things have changed. And we're going to start with looking at racial and ethnic demographics. So if you look at 2010, AGA full members, and you can see when you're looking at underrepresented minorities, Black, African American, Hispanic, and you see that full members was 3.7% in 2010. And then in 2020, that went up somewhat to 4.6%. And it's still a small percentage of the amount of gastroenterologists, and only a third if you look percentage-wise versus the US population. If you look at Hispanics, it was 4.8% in 2010, up to 6% now. And similar numbers of US gastroenterologists, but still a fraction of the total US population. If you look at Asians, it was 21% in 2010, 28% in 2020, and they're the opposite ratio. They're only about 5% of the US population. White members at 70% and now 60% are more reflective of the US population at 60%. So with respect to racial and ethnic diversity, GI does have a way to go. And though we're trending in the right direction, it's a very small trend. What about trainees? Is the future looking better? And here we actually do have better numbers. So it was 4.7% in 2010 for Black and African American, and 6% in 2020. Hispanics, 4.7% in 2010, up to 6.4%. And then total underrepresented minorities, 9.6% to 13.6%. So at least among our trainee members, we are seeing a better increase. And the hope is that these trainee members will become full members of AGA and continue their membership. But what about women in GI? So if you look at first-year GI fellows, now you can see that about 40% are female. But when you look at active GI physicians, it's only 20%. So why the discrepancy? So definitely more women are going into medicine, and therefore more women are going into GI, and then more women will be active GI physicians. But some of this number is not just the number of women who became GI, but the ones who are still practicing. And you're going to see some data to show that women in GI are more likely to go part-time or not practice at all compared to our male colleagues. So while it's great that we're up to 40% of first-year GI fellows being female, how many of those women continue to remain in GI? What about US medical school chairs? So 82% are male, so the vast majority. 14% are white female, 2% Asian female, 1% Black and African American female, and 1% Hispanic and Latina females. So a very small percentage, 18% of medical school chairs are women. And of those, underrepresented minorities are even less. However, in 2019, for the first time ever, the majority of medical students are women. And there is an increase of 6.3% in Hispanic, Latino, or Spanish origin, an increase in 3.2% in Black and African American, and 5.5% increase in American Indian or Alaska Native graduates. So that is really good. I am Sri Lankan, and I was born in Sri Lanka. And when my father went to medical school in 1970, over 50% of the class was women in Sri Lanka in the 1970s. So it took a while to get here in the US, but it's nice to see that we're there, where we have a 50% portion of medical students being women. So the second part of it is not just getting into school, but are you supported in being able to practice and work once you have graduated? So this is from JAMA Open Network. This is a longitudinal intern health study from 2007 to 2013 from the University of Michigan. 70% of participants agreed to take part in the survey, and half were women. 86% were working full-time, 11% part-time, and 2% not at all. Women were significantly more likely to report not working full-time than men. 22% of women versus 3% of men. So women are almost 8 times more likely not to be working full-time. And so the reasons for that are pretty clear. If you have children, you may want to reduce your hours, particularly when they're younger. And so if you look at women with children compared to men with children, 30% were less than full-time versus only 4.5% of men. So 9 times more likely to be part-time. There was an almost 10% gender gap in full-time employment in year 1 after training. And that became 38% by 6 years after training. So of physicians currently working full-time, women were significantly more likely to report considering or thinking about working part-time versus men. So there it was about 6.7 times more likely. This is from University of Toronto. So underrepresentation of women in the field of GI at the resident, staff, and leadership levels. And they found in their survey that women experience their careers differently than men. They're more likely to have to choose between career and family, more likely to be paid less, and more likely to experience challenging professional relationships, whether it's mentorship, other healthcare providers, and peers. And these gender-specific differences have been demonstrated in other specialty areas beside GI. So this is just an example of some of the questions. So this was from the Ontario Medical Association. They compared billing data between men and women and correcting for confounders such as days worked. There was a 15.6% unexplained pay difference. And in response to that, a Dr. Van Dyke wrote, "Dear editor, this is utter nonsense. My wife is a physician, and yes, she earns less than what I do, but this is purely because her work is office-based, whereas I'm involved in hospital care, and do a lot of ER work with a different fee structure. Also, my hours are absolutely not comparable to hers. It's way more. The billing structure is no different, and with her office work, she has billing opportunities which can be utilized other than those which I generally have to use. There's no gender pay gap, there's no hidden bias, and there's no hidden training agenda. The gap which exists is purely on account of the type and quantity of work women choose to do. It's completely untrue, false to claim otherwise. I'm fed up of such inflammatory, fraudulent statements which fly under the protective flag of political correctness. So, a question that we need to answer. So if you are doing less work, you would get paid less? Yes, but the question is it truly less work? And I don't think this study said that it was less work, because they corrected for confounders. So more women are entering medical school. That's great. More women are entering GI fellowship. That's great. But gaps in pay and leadership roles remain. So what more can we do? And the other question I think we have to honestly answer, if 50% of med school graduates are women and more women choose to work part-time or leave medicine, is this a problem in caring for the people of the country? And I think that is a question you need to be able to answer and address. And then, is a gender pay gap real? So part of our discussion can be how to improve disparities, and also how do we have diverse doctors to care for a diverse patient population. So with that rather inflammatory talk, I'm happy to take any questions or discussion that you may have.
Thanks for bringing the burning topic, Uma. So any questions from the audience? Any suggestions?
I guess I have more of a comment. Can you guys hear me okay?
Yeah.
Yeah, yes,
Okay,
Mary.
wonderful. Left alone whether or not it is universally believed that we have a problem and there's a gender gap. I personally believe that. But I think my hope and my goal for creating this society, the GI Jane Society, is for us to mentor each other, for us to be a support structure for each other, and for us, the older members of the group, to be the mentors to the current trainees. Excuse my dog. So this is really, virtual format is probably not the ideal way for us to meet, but we're kind of doing the best we can under the circumstances. But I hope that in the future, we can meet in real life and we can form real life relationships, which will go a long way to fixing whatever is wrong with our current societal structure.
Yeah, I think I think it is mentorship is very important, and I think that having somebody that is somebody in leadership above you that you can see yourself as is very important. I think I was very fortunate to be a fellow at UCSF, because even when I was a trainee, there were so many high-powered women that it didn't really seem that there was an issue. And it wasn't until I went to Mayo Clinic or some of the other places where I saw how few women there were and how there are almost no women in positions of leadership that I realized there was a difference. So in my youth, there was Terry Wright and Jackie Marr and Nora Thoreau, and people who were chiefs of their division and president of ASLD, and it just seemed like it was normal. So it didn't seem like an issue until you go elsewhere. So it should be normal for everyone to see themselves reflected in the leadership structure.
Another question, Uma, that audience is asking is they would like to hear about work-life balance and also any suggestions for young trainees about how to choose the kind of work and the work-life ratio, like personal ratio, to have that balance. Yeah,
that it's a hard question to answer generically. I think everyone needs to make their own choice. The best advice I got was from Maria Abreu, who is a rock star NIH funded researcher with 2 kids and a triathlete, and doesn't sleep. But you know, she's sort of the exception. But what she said is get as much help as you can afford. I think that was her answer, and that can be life-changing. So if you're a gastroenterologist and a mom and doing all these other things, you truly don't need to be cleaning your own toilets. And people feel very guilty about that. Get a housekeeper, get a meal service, get the childcare you need. You want to be able to spend your time doing your work and doing good things with your family. Cleaning your house doesn't necessarily have to be it. And so, you know, those are the kind of things that which is hard for trainees because they don't have the resources. But I think the more senior you become, the more support you have for domestic labor and other things, and you can focus. I think that was one of the best, like it was only 2 years ago that we had somebody come and start making meals like on a Monday that lasted us 3 days. And that was life-changing because then it was like healthy meals for our family and I didn't have to figure out what it was when I came home. But I think that's it. And the other thing is you also have to decide what makes you happy. If being chair of your division is not what makes you happy, you don't have to do it just to do it. If being on whatever organization or whatever paper or being 5 days a week, or if that doesn't make you happy, it doesn't matter. I think you really need to prioritize where your joy is and prioritize what matters to you. And I do think, and this is where I know I'm showing my age, but if you do have children, I do think there should be a priority. Like if you really don't want to have to deal with that, don't have kids. And I have a lot of colleagues who chose not to have children so they can pursue their career at the same pace and rate of their male colleagues. And then I also have female colleagues who are chairs of their division whose husbands don't work and stay home and take care of the kids. That is another option. And so I think that you do have to make sure that at least one parent is there for the kids.
I agree with Wuma. So up until this year, I was like, I'm a super mom and I'm going to take care of everything. So I didn't have help at home. I was cooking, cleaning, doing everything, but eventually it does burn you out and you're not providing quality care or spending quality time with your kids. So getting that help definitely helps. So I have a housekeeper now and another person coming in for cooking, and it has freed up my time. I spend quality time with my kids and also able to do more chart work. So definitely getting help is important. It might be spending that extra amount of money, might be you're not going for that extra vacation, but I think it's worth the money that is spent. So
yeah.
So there is another question from Dr. Lauren Blankard. She left her 18-year family practice career to join Neil Stolman. She used to work 3 days a week in family practice because 24 hours was actually equal to 40 to 45 hours. So she's hoping for some work-life balance in GI. Any thoughts on that?
I think that one of the things to have good work-life balance in GI is you need to have efficiency and you need to have support. And so one of the efficiencies, and there's a lot of ways that people have looked at this. So if what makes you most efficient is not checking your mail and your inbox every 30 seconds, though that's a good way to have actually sort of instant gratification. Okay, I cleared out 3 emails from my chart message or patient portal. But what I try to do is on my research days is I have like two times a day that I check my inpatient box and clear out what I can and not have it on all the time or not be available to do that all the time. But definitely by the end of the day, when I go home, my portal's empty. And I don't take it home unless I absolutely have to. The other issue also is having a structure, an organized structure within your workplace. And that's something that we put in at UCSF, where a message comes from a patient and it goes to the admin, and she has a protocol where she knows this kind of message goes to X, and this kind of message goes to Y, and this kind of message goes to Z. And it takes time to create that structure and algorithm and train people. And you have to constantly be working at it to have it work. But otherwise, like at the beginning of the patient portal, the physicians got all the MyChart messages, and we were the ones sending it out to people to address. And that is an inefficiency. So you look in your practice and see where the inefficiencies are, and try to make sure that everybody is working at the top of their job description. And I think that's one way that you can really try to protect your time. And that would be my main thing, is making sure you have built-in efficiencies and that you work at them.
Yeah, I agree. Having a team, a good team around you, and you have to make sure you delegate. I mean, it's not possible to take care of everything by yourself. Delegating and trusting the other team members will be the key also. Any other questions for Uma?
Actually, I see Linda on the line. Linda, what has your experience been?
Linda, you're muted. You're muted.
There we go.
Okay.
There I am.
Hey, Linda.
Hi, Uma. So, are you putting me in the old lady category too?
No,
No, just kidding. I mean, I have a 14-year-old and almost 17-year-old, and spent many years of their younger years as a single mom. So having help and not feeling guilty about it. I think the hardest thing for women is that we tend to feel guilty when we need to ask for help, as it's kind of like a sign of weakness, like I can do it, I can take on everything, sort of that Superwoman, Wonder Woman kind of facade. And, you know, I think the best thing for me was just letting go of that, like forget the guilt, screw the guilt. And just sort of be yourself, embrace yourself. And as Uma said, you know, decide what matters most for you. And like with my kids, I have a group of women in our neighborhood, and they, you know, they were my help. I mean, without them, there's no way I would have continued full-time in academics during my single mom years. So don't feel guilty, ask for help. Have your group of, you know, women, men, other parents, you know, people without children. People do help and want to help. But Uma, I guess my question for you, for a lot of our, you know, younger faculty or trainees, is sort of negotiating that ahead of time. What are some of your tips or some thoughts you have on like how to negotiate that a priori?
With your institution? Or?
Yeah, with your institution.
Yeah, you know, it's hard to say because I did so many things wrong as a young faculty. You just suck it up and just take whatever they give you. And then when you get senior enough that you have your own resources, it's easier to negotiate. I think the key thing, so what I would tell people applying for a job, so when I took my job at UCSF, I was a second year fellow, and they sent me to Mayo for 8 months for my IBD fellowship within my 3 years, but I had to sign my contract at UCSF that I would come back to UCSF at the end of my fellowship. And so there was no negotiation, there was no visiting other sites. What I would tell people is to interview broadly, because then you can see what other places do and what other people offer. And so it's very easy to stay where you are because that's what you're comfortable with. And there's a certain amount of inertia in being where you are, and you know how things work and the evil that you know kind of thing. But when you're interviewing, the only time you have power is when you're coming or you're going. And once you're there, there's no negotiation. And so that's why, the only time you have to negotiate is when you're coming in, and you have to be willing to walk away. If you're like, I am only going to be in the Bay Area within a 20-mile radius of my house in Pacifica, you are in a very poor negotiating site. And then you're going to have to just take what they give you. But if you're able to look more broadly, I think that's where, and that's where women really aren't very good, because there are a lot of factors that keep you where you are. But people who, like, forgetting him, Joel Richter, moved every 5 years, because with each move, he was able to negotiate a bigger and better contract for himself. And so I think that if you really want to negotiate well for yourself, you need to be able to walk, and you need to be able to know what your options are, but also talk to the other junior faculty. And this is also when you're very young, where a mentor comes in, and a mentor would be able to say, you know what, that's really not fair. Let me talk to them for you. Let's fix this, because that is not right.
Okay. Thanks so much. And one last question in the interest of time. So one of our male GI colleagues is asking, what advice, requests, and expectations do you have of your male GI colleagues, especially those in leadership?
So, I agree with Linda. Transparency is key. I think that if there is coming through the system, there were roles and opportunities for leadership and training that I had no idea about, because no one ever said anything. So you can't know what to apply for. You can't know what the roles are that are available to you if nobody tells you what they are. And I think that's where, for men and women in leadership, where you need to be very transparent about what is available, what kind of training can people have, what are the roles that are there, and what are the requirements for the roles. And the other thing I would tell people, no matter what stage you're in, is get formal leadership training. So if you're at an academic institution, they offer leadership classes. And in those leadership classes, one, you learn the language, because when you go for an interview, even if you're very honest and very charismatic and you don't speak in the language of the business aspects of your institution, you're at a great disadvantage. Like they have their own words, their own language, their own way of phrasing things. And if you don't go through the training and you don't speak that way and you don't think that way, you're not going to get what you need. For example, if you're like, I really want I want a nurse practitioner, and I want an RN, and I want to have capital to buy X, Y, and Z. And they're like, great, sorry, we don't have money. Because that's not how you go ask for it. You come up with a business plan and you say, this is how this is going to help the institution. This is how I'm going to grow. This is my 5-year plan. This is how it's going to help you. And you put it in words that they understand and in a language they understand. And it's not just you like whining for more stuff, because you're just going to be dismissed if you ask for it. You need to understand the business model. You need to be able to say how this is going to help the institution. And so you're asking for the exact same thing, you're doing it in a different way.
Thank you, Linda.
I can't agree more with you than that one. Just, don't just have a wish list, have a wish list of what the return on investment is with that wish list.
Correct.
Thank you, Uma, for the great talk and answering all the questions. I'm going to hand it over to Marina and to our next speaker, Dr. Barakat, but handing over it to Marina now.
Thank you. And thanks again for joining us. And there's so much rich material for discussion. I'm really, really looking forward for when we can all meet together and sit around the table and just really get into all of those topics that we're barely scratching the surface on. Well, with that in mind, I would like to introduce Monique Barakat. She is an assistant professor at Stanford, where she practices primarily interventional endoscopy. She has completed her residency fellowship and a PhD in cancer biology at Stanford. She's currently the Associate Director for Pediatric Endoscopies. To speak of her accomplishment in a short span of time might take longer than the anticipated time for her talk, so I will not do that. In addition to having an amazing career, she has 3 children and from what I understand is expecting 1 more. She is an ultramarathon runner, and I'm just going to take a wild guess that Monique doesn't need much sleep on a daily basis. We are very honored to have her talk to us about how to lead a balanced life and role of women in interventional endoscopy. With that, Monique.
Thank you so much, Marina, for that introduction. And thank you, Marina and Radhika, for the invitation and to speak with this group, and also for forming this important group. I think for those of us who are very early in our career, and I've had my appointment for less than a year, it's much appreciated that we have this kind of forum to share ideas and really understand a lot of the major issues facing women in GI in general, and just getting a better sense for how we can move forward in a productive and collaborative way. Today, I'm going to go ahead and share my screen. I wanted to discuss a little bit about women in interventional endoscopy. I'm a therapeutic endoscopist and one of the few women in therapeutic endoscopy at this point. And just to discuss, first of all, the data, and secondly, whether this is a problem, and if it is a problem, where the problem lies and how we can improve upon it. So as we heard from Uma in her great talk just now, women are definitely underrepresented in gastroenterology. About 50% of medical students, 40 to 50% of internal medicine residents are women. And women in GI fellowship were around 30% until the last maybe year and a half, at which point have increased to closer to 40%. And yet only about 14% of the nation's practicing gastroenterologists are women. So this underrepresentation is something that looks like we're close to on track to rectifying and stabilizing. It's in part related to some part-time work, as we heard from Uma's great talk. But within interventional endoscopy, women are much more underrepresented. And there are very few female GI fellows who choose to pursue careers in interventional endoscopy. And this could be for a variety of reasons, some of which just related to interest, which we'll get into a little bit later. But one striking figure is that in the 2019 ASGE Interventional Endoscopy Fellowship match, this is a match that was created in 2012, now includes between 70 and 100 programs per year, depending on how many people are taken outside of the match. But in the 2019 match, only 12% of matched interventional endoscopy fellows were women. This makes interventional endoscopy actually the most female underrepresented subspecialty among all specialties, including surgical subspecialties, which you normally consider very male dominated, like orthopedic surgery, cardiothoracic surgery, neurosurgery. The fact this may represent variation in interests and goals, but it does deserve more attention and thought about whether these career interests are really evolving over the course of training, or whether people are being discouraged from pursuing different pathways based on gender. So interventional endoscopy, just a plug, some of the things that really drew me to interventional endoscopy, it's the innovation, the substantial increase in interest in the area, and also the number of endoscopic procedures and things that can be done, endosurgical approaches. Just over the past 5 or 6 years, there are new approaches coming into play every single year, and only some of those approaches require radiation. So it's an exciting area and appeals to men and women alike, and for many reasons. But the trend of interest, the lower interest in interventional endoscopy among women seems that it starts right first year of fellowship. So this is a study, but it's the only study of its type. This was in 2006, first year ASGE fellows endoscopy course. There was an 85% response rate of first year fellows. And this is the first year fellows who had an interest in interventional endoscopy. So 78% of men, 59% of women indicated that they had some kind of interest in interventional endoscopy. The reasons for it varied a bit, and they did collect the reasons for it. Now, these same fellows were surveyed in their second year of GI fellowship. And at that point in time, they broke down the results by ERCP and endoscopic ultrasound. 77% of men were still interested in interventional endoscopy, so not much change there. But the number of women interested in ERCP went down from 59% to 22%. And that pretty striking difference over the course of a year of fellowship. It seems that women either learned more about the specialty and changed their mind about their interest in pursuing it, or had other reasons for being concerned about pursuing a career in interventional endoscopy. Endoscopic ultrasound, slightly less striking difference. Men went from 78% to 56%, women from 59% to 30%. But still a pretty significant decrease in women's interest in interventional endoscopy. So this has sparked a lot of interest among the field. And those of us, there aren't that many women who are academic interventional endoscopists, and there aren't that many women who get together to discuss these issues. But when we do at meetings, and this is an active conversation that's going on at meetings and also offline in the online community, we've brainstormed about why women might avoid interventional endoscopy. And these are some of the issues that have come up. First, the lack of interest, maybe just not drawn to the specialty. The radiation exposure comes up as a key factor, and we have some studies underway which are indicating that radiation exposure is a little bit less of an issue than we had previously thought. Also, work-life balance, family planning, and the fact that part-time practice, as Uma had brought up, that's becoming increasingly common for women in gastroenterology as a part of family planning and family balance, is just less possible. There's a volumes outcomes relationship within therapeutic endoscopy. You need to maintain a certain volume in order to maintain competency, and it's expected that you'll have your share of call. Also, the high-risk patient scenarios, those were cited by some of our respondents in informal surveys that we've conducted. Just the less flexible schedule at higher risk procedures with more consequences to procedure failure. Endoscopy ergonomics is another one, and that being endoscopes are not made for women's hands, and women who are doing procedures all the time, performing endoscopy regularly, are at greater risk for musculoskeletal injury. That risk also is compounded during the pregnancy and breastfeeding period, at which point the hormonal milieu puts a woman at greater risk for sustaining an ergonomic injury. And for an interventional endoscopist, that can be the difference between ongoing practice and the end of one's practice as he or she knows it. Other factors, the gender distribution of practicing interventional endoscopists, the fact that there's no formal study of what proportion of men and women, but the estimate is about 1% of interventional endoscopists in an academic setting are women, 1 to 3%. And in a private setting is closer to about 7 to 8%. And then just less mentorship, fewer female role models, a lot of many of the issues that were cited in Uma's talk just now, and limited opportunities. This is a saturating market. We've gone from 10 fellowships in the year 2000 to now 100 fellowships for advanced endoscopy. And the job market is a little bit more saturated than it used to be. So that leads to less geographic flexibility, and to some extent, women can be a little bit more geographically inflexible. There are a few databases that show that. And then lastly, implicit bias. And this almost certainly has a factor in terms of encouraging or discouraging individuals from certain subspecialties. Now, the academic versus private practice perception is interesting within interventional endoscopy. Academic practice is typically associated with less schedule flexibility for some interventional endoscopists, at least that's the perception in surveys that have been distributed. And the fact that there are more travel and speaking engagements, teaching and research responsibilities, even though an academic practice is best to support the complexity of procedures and the volume of procedures, in many people's perspectives, at least in the early years of an interventional endoscopist, it's not always seen as that favorable from a family and balance perspective. And then private practice can be perceived as having more autonomy in scheduling and fewer non-clinical responsibilities, but later nights, more higher clinical volumes and less backup for things like maternity leave if one decides to have more children. So in both settings, there's a perception that there's limitations in advancement for women. And women overwhelmingly report that there's a concern that there's a major impact on family life in both of these settings. Now, I mentioned radiation exposure. So fluoroscopy exposure, adverse events on reproduction. This is the second highest issue of concern among female trainees, and the reasons that they cite for not going into interventional endoscopy, despite the fact this is the subset of trainees that have an interest in interventional endoscopy. And this, we don't have definitive data on fluoroscopy exposure. We have protocols for measuring fetal radiation exposure, and those of us that have been through that process recognize that the fetal radiation exposure is really quite negligible under lead, and that it can't be considered to have much of an impact on pregnancy. So we do have some studies underway, a few multi-center studies to try to quantify this a little bit better and try to at least get the information out there for female trainees about what the true risk is associated with fluoroscopy and radiation exposure. Importantly, only a subset of our interventional endoscopy procedures now include radiation exposure. Endoscopic ultrasound therapeutic EUS has become a mainstay of therapy for a lot of disorders, and it's become more common to have a day where there's only 1 or 2 fluoroscopy procedures rather than an entire day filled with fluoroscopy procedures. Now, looking to similar specialties, one might argue that within gastroenterology, we don't have an analogous subspecialty to compare. But we can look to interventional radiology and surgery. So these are traditionally fields in which women are underrepresented. Women only comprise about 8% of the membership of the Society of Interventional Radiology. And they've undertaken some really intense and focused initiatives to improve female representation and to introduce the subspecialty to women who are choosing to match into radiology. It looks like the preliminary data based on the 2019 match show that that has been pretty successful. They've taken pretty extreme measures, which are interesting, such as the societies are sponsoring a pregnancy toolkit for women who decide that they want to have children during interventional radiology fellowship or in practice, with all of the important information that they think needs to be known by an individual who's going to become pregnant in practice. They also have family balance toolkits and work-life balance toolkits. So they make these readily available to anyone who's interested in matching into radiology so that they can understand what issues might face an interventional radiologist and maybe how to mitigate those. Similarly, the surgical societies, this has received a lot of publicity. They've increased rates of women in general surgery programs from about 14% in 2001 to 40% in 2017. And they've undertaken similar efforts to make the subspecialty and the specialty a little bit more feasible for women and even part-time women, women who decide to work part-time within general surgery. Now, one of the guiding principles underlying the progress, there was one conference between interventional radiology and surgery where they were discussing representation of women. And one of the underlying principles was that they try to teach trainees to avoid thinking too many steps ahead. So it's important to plan, it's important to have a life plan, a career plan, but also just focusing on an ideal focus within the field. Like, what is the subspecialty that you love the most? What are you drawn to? And then finding a positive avenue for making that happen, rather than feeling discouraged because there aren't female role models or there aren't, it seems like that might be an impractical lifestyle. And I thought this was kind of interesting. It's not something that we emphasize within our GI societies, but maybe it's something that we could, or we could at least emphasize within some mentorship relationships. So there are a group of about 5 of us, women interventional endoscopists within academia, who are undertaking joint projects for research to understand the barriers to recognition of interventional endoscopy as a subspecialty. And some of our early data show that really having a family, balancing the demands of the profession with a family are the biggest concerns. And that's a very valid concern, and one that, you know, I think we've all faced independently. But it's important for us to at least provide approaches that we've used to overcome that challenge and our perspectives on how that's working for us. And we're working on getting some documents together to distribute that to our interventional endoscopy colleagues and trainees with an interest. And then a couple of research initiatives focused on endoscopy ergonomics, and similar to this venue, opportunities to facilitate mentorship. If someone's interested in interventional endoscopy and they don't know any women in interventional endoscopy at their institution, to have a network of women that they can contact just to discuss the opportunities. Now, the caveat to this is most of us are very junior and we're in our first couple of years as faculty, because there aren't as many established individuals within interventional endoscopy who are women. But we can start here and try to link up with some of the established interventional endoscopists. And we've had a fair amount of support. I think there are a lot of reasons for optimism. Things are improving. We have more women trainees in GI fellowship and more women moving into positions of visibility and leadership. And I think as the trainees see more women in positions of leadership, more women in visible positions, then they can increasingly envision themselves in those positions. There are also some interventional endoscopy focused initiatives of Women in Endoscopy and the LEAD program that are trying to enhance trainee and junior faculty mentorship opportunities and exposure. And we have interventional endoscopy groups within that. And importantly, a lot of men in the field of interventional endoscopy, specifically within GI, are noting the issue and supporting female fellows who have an interest and trying to make it a possible career pathway for them. And as I mentioned, we have some ongoing among those of us within interventional endoscopy to try to understand and move the issues forward. So thank you so much for your attention and for inviting me to share some of these thoughts. Hopefully we'll have more data next time we meet that I can be able to share with you. I welcome any questions or discussion.
Marina, you're muted.
Hi,
Marina.
Monique, thank you so much for your presentation. This was very enlightening. And I love the last slide because I am an internal optimist and I always try to look at the positive side of things, right? And I just, let's see, do we have any questions? We do. Okay. Thank you for having us for discussion. Okay, thank you so much for that comment. Let's see, do we have any questions for Monique? I know it's late and everybody's getting tired of staring on the screen for the morning. So we have a lot of wonderful comments. I find it useful to refrain for any women entering the male-dominated field, find an ideal focus and explore positive avenues for making that happen rather than focusing on the lack of similar role models. Thank you, Lauren, for that wonderful comment. And I absolutely agree. Again, this goes back to my eternal optimism. Since we don't obviously have any more questions, I'm going to just start closing the meeting. Thank you again so much for coming. I think we have a lot of reasons to be optimistic. We've had greater than 60 amazing women participate in this virtual meeting on a Sunday morning. This is fantastic. I think I'm looking forward to meeting all of you in person and to have a meaningful relationships going forward. I think there are so many opportunities for us as women in medicine and for us as physicians in general. There's one thing I do want to mention that I find particularly helpful in my life as a woman in medicine is acknowledging your help, right? A lot of us have very non-traditional home setups. Certainly mine is non-traditional. My husband doesn't work. He is the mom at home. So really making that an okay scenario and making our helpers acknowledged in our success, I think is very important. And I'd like to finish this with one of my favorite comments from Lewis Thomas. And this is what motivates me to be a physician and a woman in medicine. An ungovernable curiosity about people of all sorts, a degree of modified hopefulness for human condition, and a steadying affection for the species. And with that, thank you so much, and I look forward to seeing you in person the next time.